Hello, everybody, and many thanks for the invitation to this wonderful conference, and to Dr. Sriram and Dr. Divakur in particular for putting together such a fantastic program. I'd like to start coming from Australia by acknowledging the country from which I'm speaking, which is the Bidjigal people of the Eora Nation of Australian Indigenous peoples. And like many First Peoples the world over, Aboriginal and Torres Strait Islander peoples are disproportionately affected both by pregnancy complications and by non-communicable diseases. But I do love this diagram from NAIDOC, our Indigenous Peoples Week, a couple of years ago, with their motto, "Because of her we can," which I think says a lot about our journey in women's health, both Indigenous and not. Just in terms of disclosures, I do receive some government and non-governmental organisation funding, but no industry or commercial funding, and I have no conflicts of interest to declare. So what I'm going to give an overview of this talk, and I know lots of what I'm going to talk about will be gone into greater depth by the other speakers, is pregnancy as a stress test for life, and a bit about pregnancy and non-communicable diseases and the effect of pregnancy complications on a woman's health life course, and then a little bit about where we can go from here and opportunities for impact and improving women's healthcare. So I guess there's sort of three main categories. There's the science, which is that pregnancy is a window for us into a woman's future health. There's opportunity in that pregnancy, and also potentially preconception and postpartum is a time when the vast majority of women, including in low and middle income countries as well as high income countries, will have contact with healthcare services. And there's great opportunity for impact in that pregnancy and preconception and into pregnancy are times when women may be more receptive to preventive healthcare and improving their life course, health, and that of their children. So in terms of pregnancy being a stress test for life, pregnancy is a major physiological challenge in many ways, like sort of running a 9-month marathon. And I'm not going to go into every change that happens to the body during that time, but a couple of big examples. The cardiovascular system, as shown in the graph, huge changes such as a 40 to 50% increase in cardiac output, and that should be stroke volume, sorry, not PV, 15% increase in heart rate, and a decrease in peripheral vascular resistance. The uterine circulation greatly increases, and there's a whole new organ, the placenta, as well as the baby, that arises and has to be adapted to across the course of the pregnancy, and also relative anemia. Then in terms of another major sort of system, and of course everything interrelates, in terms of metabolism, pregnancy is a time of relative insulin resistance and shares features with the metabolic syndrome. And in particular, glucose is the main fuel of the fetus, and so the various pregnancy hormones and physiology of pregnancy is set up to maximize maternal glucose levels and have an anti-insulin type effect. At the same time, obviously, there's large increases in weight and fat mass, partly from the fetal unit and the placenta and the amniotic fluid, also a bit more generally. But at the same time, the body actually gets quite energy efficient, and really there is only a moderate increase in the energy expenditure. So women really do not literally need to eat for 2, but for more like 1.1 or 1.2. And so overall, pregnancy is providing us with a unique window into a woman's likely future health. And we need to use this information because as this slide shows, this is from Lancet Global Burden of Disease study a few years ago, leading causes of death in all except the lowest income countries are now non-communicable diseases, acknowledging, of course, that with the COVID-19 COVID-19 catastrophe 2020 and 2021 may have a blip in this, but the overall trend is towards non-communicable diseases such as ischemic heart disease, stroke, Alzheimer's disease, diabetes, becoming leading causes of death for women across the world. Now, obviously, we all have to die of something, but it's not just your ultimate cause of death where the NCDs rank very highly. They're also leading causes of disability-adjusted life years for women, so morbidity, essentially. And in terms of leading risk factors leading to early death and disability, this same Lancet Global Burden of Disease study, we can see that in women, 3 leading risk factors for early death and disability are all things that we both measure and which can become apparent either for the first time or as a follow-up during pregnancy. So high systolic blood pressure, high fasting plasma glucose, and high body mass index. So in terms of the science, consistent with the global march of non-communicable diseases, women are now entering pregnancy with more risk factors and higher rates of existing non-communicable diseases. So the graph on the right is from my home country of Australia, which is not pregnancy specific, but is basically showing that there's a very high Australian adult prevalence of overweight and obesity in women as well as men. And that this is particularly acute in the regional and remote areas and in those with lower socioeconomic status. But overall, globally, we've got higher maternal age, higher BMI, and pre-pregnancy chronic disease rates such as hypertension and diabetes have been rapidly increasing in both low and high income countries, and up to about 5% in some settings. And pre-existing disease and non-communicable disease risk factors, of course, both increase the chance of poor maternal and child outcome in the current pregnancy, but very importantly, and why we're here at this conference, into the future. So women also commonly have complications of pregnancy that are strongly tied to underlying and ongoing non-communicable disease risks. And just a couple of big examples: gestational diabetes, 1 in 6 pregnancies globally, and hypertensive disorder of pregnancy, 1 in 10 to 1 in 20 pregnancies globally. And as I'll discuss a little bit in subsequent slides, these aren't old age risks, they're things that impact in the middle years. So evidence around specific diseases, I believe, will be talked about in much more detail by other speakers, but however, I do want to touch on a few of the most common pregnancy complications as a window to a woman's future health. So in terms of hypertensive disorders of pregnancy, which is my particular area of research, there's extremely strong evidence now from hundreds of thousands of preeclamptic pregnancies and millions of normotensive pregnancies that preeclampsia is strongly associated with ongoing health issues for the mother. The evidence is less extensive for gestational hypertension, so just blood pressure without the multi-system features of preeclampsia, but the long-term risks appear to be similar. So as obstetricians, we've previously been thinking of gestational hypertension, unless they go on to get preeclampsia, as a fairly benign disease, but in the long term it certainly is not. And chronic and pre-pregnancy hypertension, of course, is already an established cardiovascular disease risk. And just in terms of what the health risks are after HDP, as you can see from the table, about a doubling in ischemic heart disease, stroke, diabetes, and that is type 2 diabetes, and that is even if the hypertensive pregnancy was not affected by diabetes. It's many times more if it was, but just showing that these sort of cardiovascular and metabolic risks run together. Tripling of chronic high blood pressure and kidney disease 5 to 10 times. Now, of course, because we're talking about these conditions occurring in fairly young women, HDP, the absolute risk at the time is very low, but the increased relative risk is noted within 5 to 10 years after pregnancy. So there's no real free kick in terms of the increased chronic disease risks. As best of people have been able to account for in epidemiological studies and routine data, the risk is not solely due to having other cardiovascular disease risk factors. And certainly there's higher ongoing risks if there's recurrent preeclampsia, early onset preeclampsia, and having other cardiovascular disease risks. And work that I published from New South Wales last year, led by Claire Arnott, cardiology colleague, showed this sort of interaction of preeclampsia, smoking, and premature birth secondary to preeclampsia, was more than 20 times increased relative risk. And although children are mostly very well, they also do carry some long-term risks, on average higher blood pressure and weight than their peers. In terms of gestational diabetes, another very important and increasingly common pregnancy complication, we've also known about increased type 2 diabetes risk after gestational diabetes for many years. And a meta-analysis in 2009 put the odds ratio at about 7 times. The cumulative incidence highest 3 to 6 years postpartum. So again, we're not just talking 20 to 30 years down the track. Again, unsurprising, I guess, the added risk factors in that they're similar to the risk factors of having GDM in the first place, high BMI, non-white ethnicity, a family history, and also your severity of gestational diabetes as measured by early onset, whether you needed insulin, and if the OGTT values were high. And then gestational diabetes is also independently associated, and this has been less recognised until more recently, with increased risk of chronic hypertension and increased risk of cardiovascular disease. So those non-communicable disease risks running together, as it were, the overlap between various cardiovascular metabolic syndrome features and complications of pregnancy. One issue that I believe is very common and very important to India is that of anemic pregnancy. This is most commonly iron deficiency anemia, and overall it's extremely common, 10 to 20% in high income countries, up to 50% in low middle income countries and subgroups within high income countries. Obviously some short-term effects, but also anemia is in some ways the canary in the coal mine, in that it's associated with both infective and non-infective chronic conditions, as shown in the table. And so there's long-term maternal risk associated with the effects on the associated chronic underlying conditions in terms of worsening. And just to point out there that in terms of the non-communicable diseases, diabetes shows up again, and the anemia along with the diabetes increases your risk of mortality and worsening nephropathy and neuropathy. So what do we think is going on? And look, this graph is using hypertensive disorders of pregnancy as an example, but it can be it can go for diabetes, type 2 diabetes, etc. as well. And so the theories in terms of whether we think it's kind of chicken or egg in terms of complication of pregnancy, non-communicable disease risk, or a bit of both, is first of all one big theory, and I think my esteemed colleague Professor Talaganathan has very compelling arguments about this one, is that women come in with a predisposition and pregnancy unmasks that predisposition, which in terms of hypertensive pregnancy manifests in terms of preeclampsia or gestational hypertension. Then if we do nothing about it, they continue on their merry way with their higher risk and cardiovascular disease on average 10 years earlier than women with normotensive pregnancy. Another theory is that there's something about the complicated pregnancy that permanently or unfavorably alters a woman's cardiovascular system. So possibly in terms of preeclampsia, you know, the thin woman with no cardiovascular risk factors and no family history who gets early onset preeclampsia, maybe in her there's actually something that's not her underlying risk, but that we've added to with the preeclamptic pregnancy. Possibly it's a bit of both. But regardless, the risk is there, and the question therefore becomes where to from here. What can we do about it? So I guess my two biggest points, and it's wonderful that there's this multidisciplinary conference has come together, is firstly smashing healthcare silos. For too long we've had primary care, physician care, pregnancy care in our own separate silos and not necessarily communicating well to help women's lifelong health. And rather than thinking of pregnancy as a moment in time, it needs to be seen as part of a woman's overall lifelong journey and an opportunity for intervention. So the big opportunity with pregnancy care is that globally, the vast majority of women will access antenatal care with a skilled healthcare provider at least once, and almost 2/3 receive at least 4 visits. Yes, there are disparities across the globe in how this happens, and certainly disparities in terms of early antenatal care, so the first visit at less than 12 weeks. So absolutely, we need to work on both equitable quantity and quality of pregnancy care, including the provision of early prevention. So, for example, encouraging exercise, which does help decrease both hypertensive pregnancy and potentially gestational diabetes, and assessing in terms of aspirin for those at higher risk of hypertensive pregnancy. But despite the limitations, there's obviously a huge opportunity for engagement with women and maternal health plus, so the overlap of non-communicable disease assessment and basic antenatal care, because many of the things we do in pregnancy care, like take a blood pressure, dip the urine, do blood sugar, are also fundamental to non-communicable disease assessment. Preconception care is another potential point for intervention. A bit harder because up to 50% of pregnancies are unplanned, and unfortunately those rates are not much better in those who already have pre-pregnancy chronic disease. But there's certainly great potential in the sexual and reproductive health services to adopt a life course approach and address whole of care rather than single issues. In fact, it was my own GP who said every refill of the pill is an opportunity for preventive health care. I think that's well worth mentioning. And also the inter-pregnancy interval, trying to avoid the black hole of postpartum care. And that's where a lot of my research is currently focused. In terms of impact, although there is some conflicting evidence on this, studies in a number of settings generally support that pregnancy is a time women are receptive to health behaviour change, with women at high risk or who perceive themselves as high risk are more receptive, as are those of higher education level, and offers us as healthcare professionals a unique opportunity to improve women's health. And colleagues from the George Institute in the India and UK, for example, currently working on smart health pregnancy, so to detect and refer high risk pregnant women in rural India to try and prevent NCDs. So in terms of what do we need to do overall to prevent long-term issues, acknowledging risk is not destiny. So my sort of things are around, suggestions are around that we need better triaging of risk. We need education and therapeutic intervention strategies. We need to implement, and then we need to get more evidence of effectiveness. And all of these things, unfortunately, still need a lot of work. So my own team has recently published on the triaging risk part of things. We've been following women after normotensive or hypertensive pregnancy for the first 5 years. And the 6-month data in the table is basically showing that women after preeclampsia clearly have higher blood pressures, more abnormal insulin resistance resistance scores and higher BMI than those after normotensive pregnancy, but still at levels well below what have traditionally been considered hypertensive cutoffs. But the healthy young women have really much lower results. So we probably need to have our feelers out at a lower level than we've been used to in terms of, for example, blood pressure postpartum. Then in terms of realising impact in terms of what intervention and education strategies we might use, I do emphasise here that I think everybody needs to consider what's best for their local setting. Possibilities from the HDP example could include postpartum clinics, could be online or telephone or mHealth and app lifestyle behaviour change interventions, and that has been tried a bit both in the US and in Australia by colleagues at University of Newcastle, and maybe a bit of both. So we're currently looking at BP squared, which is a randomised follow-up of follow-up clinics, plus or minus further telephone-based lifestyle behaviour change. But we've certainly found when we've asked different things in terms of what women want and when and how. So in Australia, for example, they do want the information face-to-face from a healthcare provider and supplemented by things like online. In China, after GDM, they're much more preferring the idea of mHealth and something they can do on their own time. And we also have to be careful not to increase disparities between groups by mHealth and the telephone services, which tend to be more used by women of higher socioeconomic backgrounds. So we need to find a way to reach everyone. So just to conclude, although we don't have all the answers yet, I think it's really important that we push forward with implementing interventions, not just characterising the disease toll. So rather than admiring the pathology, so noting that this is an issue, we all need to move forward, if we can, with starting to treat it. So targeted screening, modifications, early treatment. And I would just note that this is adapted from an editorial from the BMJ almost 20 years ago, and we're still unfortunately not there yet in terms of good structured programs, and I would encourage everybody to push forward with doing just that. I would like to acknowledge my wonderful multidisciplinary team at St George Hospital in southern Sydney in New South Wales, and again, thank you very much for the opportunity. You've got a wonderful program ahead of you. I wish you all the best for your conference, and I'm very happy if anybody wants to get in touch with me through my email or Twitter. Thank you very much.